Pulmonary embolism is a serious condition caused by blood clots in the lungs. With nearly 900,000 cases each year in the USA, accurate and timely diagnosis is essential. This study, conducted at the New York City Health and Hospitals Jacobi Medical Center, aimed to evaluate the utilization of validated diagnostic predictive tools like the Wells score, Years algorithm, and revised Geneva score, alongside D-dimer testing in patients with PE. The researchers also compared the sensitivity of these tools along with D-dimer testing. Over 1 year, the Group A researchers reviewed the cases of 917 patients who underwent computed tomography pulmonary angiography scans to rule out pulmonary embolism and extracted all relevant data. Following this, 2 reviewers per patient in Group B, who were blinded to the results of D-dimer and CTPA scans and to each other, estimated the clinical probability of PE by calculating the Wells score, Years score, and revised Geneva score. A patient was considered as low clinical probability if both independent reviewers deemed them to be in the low risk category. The clinical probability of PE was considered low by both independent reviewers in 563, 487 and 184 patients based on the Wells score, the Years algorithm and the revised Geneva score, respectively. D-dimer testing was conducted in fewer than half of patients who were deemed to have a low CP of PE by both reviewers. The combination of low clinical probability and a D-dimer value less than 500 nanograms per milliliter based on the Wells score, Years algorithm and modified Geneva score was estimated to yield a sensitivity of 82%, 83% and 75% respectively in ruling out PE. The results were found to have a similar trend when an age-adjusted D-dimer cutoff was used. Hence, this study showed that only a small number of patients with a low clinical probability actually had PE, most of which had subsegmental PEs. It is important to mention that subsegmental PE is frequently overdiagnosed, and thus it is likely that some of the few subsegmental PEs missed were false positive findings. Of the 2 segmental PEs that were missed, patients had clear risk factors of malignancy and recent surgery, and none of them were hemodynamically unstable. All 3 tools had an estimated sensitivity of less than 50% to rule out PE when used without D-dimer. When these scores were combined with D-dimer testing using a cutoff of less than 500 nanograms per milliliter, they yielded a negative predicted value of over 95%. This highlights the tool's value in ruling out PE and shows that the excessive use of CTPA was likely secondary to the suboptimal utilization of diagnostic predictive tools. In conclusion, a significant proportion of patients underwent CTPA despite having a low CP of PE due to the suboptimal utilization of validated diagnostic predictive tools and D-dimer testing, potentially leading to excessive chest imaging and increased healthcare costs. Promoting the use of validated diagnostic tools along with D-dimer testing can enhance patient safety, reduce unnecessary imaging, and optimize resource use in healthcare settings.